Good afternoon. Thank you very much to the organizers of this great meeting for inviting me and giving me the chance to cover the challenging topic of optimization of conditioning regimen in acute leukemia. When you look into the literature on conditioning, the comparison of RIG versus MEC regimen is one of the most intensively discussed topics. I will not go into details of the large number of retrospective comparisons that have been performed, but just try to summarize the message of all that studies. And this is the so-called equitation of RIG, which means reduced non-relapse mortality plus increased relapse incidence equals comparable outcome to MEC in many studies. There are some prospective trials that have taught us some interesting lessons that might be relevant for the clinical practice. The first is based on a randomized study performed by the American group comparing RIG and MEC regimen. And in this study, it was shown that MEC, represented in these curves by the blue line, might be preferable for more proliferative diseases like AML based on the huge difference on relapse incidence that was clearly higher after RIG transplants. In contrast, as shown here in the results from the study by Nicholas Kröger, RIG might lead to equivalent results in less proliferative diseases like MDS. So choosing the intensity of the conditioning on the basis of the proliferative capacity of the underlying disease might be a possible way to improve outcome. Based on these experiences with RIG regimen, decreasing toxicity without losing anti-leukemic efficacy was a clear aim for the development of new conditioning regimen. There are two prospective trials that successfully use this kind of strategy. And the first one is the study published by Rambaldi and co-workers 5 years ago. And the study compared the so far standard conditioning consisting of MEC IV busulfan plus cyclophosphamide to a new protocol introducing fludarabine instead of cyclophosphamide in combination with myeloablative doses of busulfan. The study was performed in patients between 40 and 66 years suffering from AML in complete remission and transplanted from an HLA identical O1 mismatched donor. And these are the results. As you can see from the cumulative incidence plots, non-relapse mortality made the difference because NRM was clearly lower in the busulfan plus fludarabine group as compared to the group of patients receiving busulfan plus cyclophosphamide. In contrast, anti-leukemic efficacy, represented here by the cumulative relapse incidence, was completely unaffected. Nevertheless, these differences led to a clear and highly significant advantage with respect to leukemia-free survival for the busulfan plus fludarabine regimen. The next study that I would like to discuss in this context is the comparison performed by Dietrich Behle and co-workers from Essen and published earlier this year, who compared busulfan fludarabine with the combination of triosulfan and fludarabine. Triosulfan is another alkylator with high anti-leukemic efficacy but very low extra hematologic toxicity. And the setting was comparable to the Rambaldi trial, elderly AML patients in complete remission having an HLA identical O1 mismatched donor. And similar to the Rambaldi study, we saw improved leukemia-free survival in this study, also overall survival with for the experimental group, meaning for the fludarabine triosulfan group. And this again was not based on a difference in relapse incidence, but on a clear advantage with respect to non-relapse mortality. So based on this data, it seems that the introduction of less toxic drugs with equal anti-leukemic activity may be an effective strategy towards better outcome after allotransplant. However, how can we estimate the toxicity of a given conditioning, in particular when the huge number of different regimens that are available is considered? So far, we just have the already classical trinity of clearly defined non-myeloablative and myeloablative regimen, and the majority of regimen in between, all summarized as RIG. To address the limitation of this relatively rough classification scheme, the Acute Leukemia Working Party recently has developed the so-called transplant conditioning intensity score by assigning intensity weight points to frequently used components of conditioning regimen. And this allowed the classification or the categorization of the conditioning regimen into three groups marked here in red, green, and blue that are characterized by similar toxicities. The score was later on tested in a large cohort of more than 8,000 patients transplanted for AML in first complete remission. And as you can see here, the score was perfectly able to predict early and also late non-relapse mortality, both in the younger and also the elderly cohort of patients, meaning that probably this kind of schema might help to estimate the toxicity of a given regimen much more precisely than just classifying it as RIG or MAG, and therefore support to choose a suitable conditioning regimen for a given patient. The introduction of potentially more potent anti-leukemic drugs or drug combinations into the conditioning regimen was another strategy that has been discussed or tested extensively. And one principle was the so-called sequential therapy that has been introduced by the Flamsa-Rig regimen by our group about 15 years ago. This protocol has been discussed quite often, so just let me go very quickly through it. It consists of a block of intensive chemotherapy followed after 3 days of rest by reduced intensity conditioning that in the original form of the protocol consisted of TBI 4-gray and cyclophosphamide plus ATG. And after transplantation, early tapering of immunosuppression and prophylactic DLI using an escalated dose regimen were integral part of the protocol. These are the results of the studies in relapse and refractory AML that have recently been updated. And as you can see, using this protocol, it was possible to rescue about 1/3 of the patients, which was particular at the time when the study was published for the first time, the first regimen that really achieved this kind of results in refractory AML. In our group in Munich and Augsburg, we have tried to transfer the sequential-based approach to the haploidentical setting and use Flamsa or a clofarabine-based cytoreductive block, followed by a slightly variated version of the original Baltimore protocol. The difference to the original protocol consisted in the substitution for TBI by either melphalan in patients with AML or treosulfan plus minus etoposide in patients with ALL. Result of a series of 33 patients that we had published 2 years ago with high risk and refractory AML. All patients had active disease at time of transplant, and the median blast count in the bone marrow before starting of cytoreduction was 30%. And these are the results. It was very well tolerated with a very low non-relapse mortality rate. Relapse rate was more or less as expected in this kind of high-risk patients. And this led to an overall and leukemia-free survival within the same order of magnitude that we had achieved in the HLA-identical setting. The second group of particular defined regimen is the double alkylator-based protocols, and the most prominent representative of this is the TBF regimen that has originally designed for cord blood transplantation, was later on used as a platform for myeloablative haplotransplant, and was recently also used in matched donor transplant. This is the haploidentical regimen used mostly in Italy, consisting of tiotepa, total of 10 mg per kilo, fludarabine, and a myeloablative dose of busulfan. And like the FLAMSA protocol, the TBF regimen was most successful in advanced stage AML. This is the most extensive study published 2 years ago, consisting of 150 patients with high-risk AML, about 1/3 with active disease and 2/3 with ELN high risk, and all patients received haploidentical transplants. And these are the results. As you can see, the transplant-related mortality was impressively low, and in particular in the patients with advanced stage and older age, the protocol achieved astonishing results. So each of these regimens seemed to be a relevant step forward with respect to the treatment, at least of high-risk patients. But the question is still open whether there is an optimal regimen or does the regimen really matter. This question has not been addressed in a prospective trial, but there's a retrospective study recently published by the Acute Leukemia Working Party that compared Flutreo versus TBF versus FLAMSA-based regimen in the setting of relapsed and refractory patients with AML transplanted from a related donor. And these are the results, and as you can see, obviously there is no difference with respect to any outcome parameter. So the regimen obviously does not matter at all, at least in this real-world scenario in a retrospective analysis. And this brings me a little bit to the conclusion that there is a limit of what we can achieve by combining classical anti-leukemic drugs in the different conditioning regimen. Another possible strategy for optimization of the conditioning relies on an extended therapeutic drug monitoring that allows for individualized drug dosing. In a MEC busulfan-based regimen, the dose adjustment based on pharmacological measurements is already a kind of standard. However, this strategy is recently also used for 2 other drugs. In one study, a group from the Netherlands looked for the fludarabine exposure during the conditioning prior to allotransplant and correlated the data with outcome variables. The study was based on a cohort of 192 patients, about 2/3 had a malignant disease, and all patients received a uniform myeloablative flubu ATG-based conditioning. The pharmacokinetic calculation of fludarabine exposure was performed using the AUC strategy, and later on retrospective correlation with outcome was performed. The endpoint was event-free survival, and graft failure, relapse, and non-relapse mortality were counted as events. And as you can see from this curve, it was clearly possible to find an optimal fludarabine exposure that was associated with the lowest probability of events, whereas both underexposure and overexposure led to an increased event probability. Looking at the Kaplan-Meier plots, you can see that the group that had optimal fludarabine exposure, that is represented by the green line in these figures, had a clearly superior event-free and overall survival. And this was based, as shown here in figure C, by a clearly reduced non-relapse mortality. In contrast, graft failure and relapse incidence, as shown in figure D and E, were completely unaffected by the fludarabine exposure. Having found this, the author went back to the patient chart and checked for predictive factors for fludarabine exposure. And what they found was that both patient weight and renal function were clearly associated with fludarabine exposure, much better than age and body surface, on which we normally base our fludarabine dosage. And so they also hypothesized that these 2 values might be a better base for dose adjustment that could lead to improved outcome after transplant. The other pharmacokinetic study I would like to discuss with you is a study also coming from the Netherlands, from the Leiden group, that associated the ATG exposure and survival outcomes after allogeneic transplantation. The setting is quite similar to the last study, uniform transplant setting, unrelated donors, uniform, in that case, non-myeloablative conditioning consisting of thymoglobulin according to the local standard, fludarabine and low-dose TBI. And the activated ATG levels were measured and the individual exposure was calculated and later on retrospectively correlated with outcome data. And as with the fludarabine exposure, it was clearly possible to define an optimum ATG exposure that led to best outcome results, whereas both the under and the overexposure of ATG led to inferior outcome. Also seen here in the Kaplan-Meier plots. The blue curves represent the optimal exposure, and I would like you to focus on the dotted lines, which represent outcomes adjusted for other risk factors. And as you can see, both overall and event-free survival were clearly superior for those patients achieving an optimal ATG exposure, and this was based both on lower non-relapse mortality and to a less extent lower relapse-related mortality. And as in the fludarabine study, the authors of the ATG exposure study asked themselves how to achieve optimal ATG exposure. What they found is that in particular in patients below the weight of 50 kilos, the kinetics of ATG were completely independent from weight, so weight was not a good basis for those calculations. In contrast, the peripheral blood lymphocyte counts was highly predictive for ATG clearance, which is why the authors tested the hypothesis that ATG dosing based on lymphocyte count might be a successful strategy. And they did this by simulating ATG exposures in the computer based on the 3 commonly used dose recommendations and compared this to lymphocyte-based dosing. And to make a long story short, as you can see here in picture D, when the lymphocyte-based dosing was used, independently from the patient's weight and lymphocyte count, all virtual patients landed in the optimum area of optimal ATG exposure, which was not the case in the other 3 weight-based dose regimens that are commonly used. For the final slides of my talk, I had planned to show you some studies on integration of new therapeutic principles or novel drugs into the conditioning. However, when I looked into the literature, I was relatively disappointed because there are basically no studies using this idea to improve the efficacy of conditioning regimen. There is just one study recently published on the EHA meeting by a group from China that used CAR T cells in AML. And the construct that was used in this study was a bispecific CAR addressing both CD33 and CLL1, which is an antigen also expressed on the majority of myeloid leukemias. The CAR was planned to target both a bulky blast population and the leukemic stem cells, and the myelotoxicity against the healthy stem cells was well calculated in the protocol, since the protocol consisted of 2 phases, one the CAR T cell phase and later on followed by a RIG allotransplant to salvage from the myelotoxicity caused by the CAR. The results are still rather preliminary, since this is a phase 1 trial that is still ongoing, but has included so far 9 patients with refractory AML. Nevertheless, MRD negativity has been achieved in 7 patients at 4 weeks after CAR T cell infusion, and 6 of these patients went over to an allotransplant. Unfortunately, neither the interval between the CAR and the transplant nor the reconstitution of hematopoiesis after the RIG transplant was reported. Nevertheless, at the end, 5 of the 6 patients went out with a 100% chimerism and complete response. In summarizing the results of different strategies for optimization of the conditioning regimen, we can say that in randomized controlled trials comparing different conditionings, The reduced toxicity has decided the race rather than the difference in anti-leukemic efficacy, at least in elderly patients with AML. The new transplant conditioning intensity score focusing on toxicity or non-relapse mortality might be a useful tool for the choice of a regimen in a given patient. Innovative protocols as the FLAMSA or the TBF protocol have certainly contributed to improved results, in particular in high-risk or advanced stage patients. However, differences in the anti-leukemic efficacy among these protocols are at least not that evident. Intelligent drug dosing based on pharmacokinetic measurements might help to improve outcome by individualization of doses, avoiding both under and over exposure, which might both be disadvantages. And finally, so far we have very few protocols that really include innovative drugs or new therapeutic principles. So this is definitely an area with large room for improvement and for further research. And by this I want to finish. I thank you very much for your attention and I'm looking forward to the discussion.